Yeah.
And I think we're a couple of minutes early, but I think, Anna, if we could carry straight on with the next speaker. The next session is an international approach, which personally I think is very exciting and interesting. And we've got two speakers, one from Czechia, which is what we used to know as Czech Republic, and one from Ghana in Africa. So I'd like to introduce the first speaker, who is called, I think it's Vladimir Von Trachek, who is actually talking, isn't it? It's not anyone else from that centre. And he is the head of the Proton Therapy clinic in Prague, and he's going to be talking about the clinic. He's also going to be covering policies in the EU perspective on policies and collaboration across the EU and the current statements of treatment. So thank you, Vladimir.
Hello, everyone. It's a pleasure for me to hear me.
Yes, we can. Thank you.
So it's a big pleasure for me to present here our clinical work. It's a bit, say, other part of the care for the patients which actually have already had cancer, the breast cancer, and we are trying to treat them with radiotherapy. So I have a presentation. I will try to share the screen if it's possible. Do you see the screen?
Yes, we can see it. Thanks, Vladimir.
Okay. So first of all, let me say something about our center. We are a proton therapy center in Prague. We have 4 treatment rooms, and we are treating the quite wide spectrum of all cancer patients. And a couple of years ago, we started to treat also the breast cancer patients, mainly young left breast cancer women, because we see the advantage of using protons in such cases. So radiotherapy is, this is just a short summary. It's a non-surgical modality for treatment of the cancer. Non-surgical means that you don't enter the patient body. It's treatment from outside, and we are using the invisible radiation to hit cancer cells and deactivate them, which basically means we kill them or we prevent them to duplicate, to grow. For a lot of cancers, this is a cost-effective approach with high cure rate, and basically maybe 40% of all cancer patients can benefit from radiotherapy in general. In cancer treatment or management of breast cancer, radiotherapy has a stable role, and usually all the patients are treated with photons, with linear accelerators, which are spread all over the world, and this is the usual modality to treat the breast cancer patient. Usually the treatment with the radiotherapy is done afterwards, after the surgery, after actual removal of the tumor from the breast. But as I said, conventionally is used, the conventionally used particle is photon. So usually patients are treated on linear accelerators with Proton Beam. The Proton Beam is using the protons as a projectile particle. So we have a quite powerful accelerator which accelerates protons to high energies, so they can penetrate the patient body to the depth we need to hit the cancer cells. Why we are using protons? Why they are more efficient than photons in this case? Protons are charged elementary particle, Charge means if it has a charge, we can modify and change the trajectory of the particle by either electric field or magnetic field. So we can target precisely the protons to the place in the patient body we need to hit. And elementary particle means that it is not breaking into parts. So it is just one particle. It cannot be damaged during passing through the matter. What mean high rest mass? It means that it's a heavy particle, but you have to take into account that the word heavy here is meant in a sense of elementary particles. So it's heavy particle, but in principle it's weighing nothing. But if it has high rest mass and elementary charge, it has a specific dose distribution into the depth, and the particles which are more heavy, they are less scattered in matter, basically in patient body. This is the picture of Bragg peak shapes, the shape of the depth curve, which is called Bragg curve. Now you can see that, well, basically the graph shows how the energy is deposited into the depth of, in this case, water. In the patient body, this is nearly the same because patient people are mostly made from water or consist from water. So you can see that at the beginning of the track of the particle in the patient body, there is a less energy delivered to the tissue, and when the particle is slowing down, and after it slowed down, they deposited more energy in the place we need it. So in principle, we can select the depth where we want to deposit most of the dose, and if we select the correct place, I mean the place where the tumor is, then the irradiation is more effective. This is how our beam looks like on lateral profile. What I want to show by this picture is that the small pencil beam is hitting very precisely the place we want. We call it a set of spots or single pencil beams, and you can see that the width of the pencil beam is a couple of millimeters. You can see here on the graph that the width of the beam is a couple of millimeters, in this case, say 7 millimeters. So with 7 millimeters beams, we are hitting precisely the target of the target, in this case, the tumor site. This is for sure the same for all our patients. And this was just a small physics introduction. Maybe it was not too clear, but I think it was just to display what is the physics behind. And here is a bit of discussion why we are using protons if we can use photons. When we are using protons, we can select the dose, the depth where we deposit the dose, the energy of the particle. So the treatment is more conformal. Down on the slide, you can see two slices, CT slices, where of a patient with breast cancer. The red area is the target volume, the area where the tumor cells are, and you want to irradiate it as much as possible to kill all the cancer cells. But in the very close to this volume, there are so-called critical organs or organs at risk, which have to be somehow spared. The reason is that if the radiation is hitting the normal tissue or the healthy tissue, it can also create some adverse effects, some so-called toxicity of the treatment, and this is the situation we would like to avoid. So you can see on the left the typical treatment plan done by photons, by high energy photons on modern linear accelerator. On the right, you can see the proton plans. The lines with different colors are connecting the points with the same dose, and the colder color is, the lower dose is deposited into the tissue. So here you can clearly see that with photons, you are also delivering quite a high dose to the part of the lung, the left lung, and the part of the heart. Heart is the orange ball in the center of the picture, and the lungs, left and the right lung, you can see there also. So by protons, you can see we deliver quite high dose to the target volume, but we are sparing heart, we are sparing the ipsilateral lung, in this case the left lung, and also heart veins. Most important is the left anterior descendants vein, which is if we irradiate it too much, it can shrink and it can cause problems later on, and maybe cause also the type of heart attack. So how we treat with protons, we started since quite large amount of patients since 2018. We have two so-called fractionation schemes. It means how the dose is delivered to the target. One scheme is so-called normal one. It's two grays. Gray is the unit of the dose, delivered 25 times, and then we just treating the small volume where the tumor was originally located with additional 8 fractions. So in total, patient comes to our center for treatment 33 times. And in a case we have we call it a shorter regime, which means the patient is delivered a higher dose per one session, per one fraction. And in this case, the whole treatment is done in 20 sessions. And as I said, we treated several hundred patients since 2018. So I can say we have a quite good experience with treating breast cancer patients. Our treatment technique is that we are using two fields. One is from the front of the patient, and second one is oblique. To be sure that we are really hitting the target, we are really hitting the volume we would like to treat, we use clips as fiducial marker. The clips are inserted during the surgery into the breast, and they are located in the area where the tumor was. What we are using next is so-called deep inspiration breath hold, because the treatment itself takes a couple of minutes. And in a case that the patient is breathing freely, then for sure also the chest wall is moving. And there is a risk that during this movement, the beam is not hitting exactly and precisely the target. So we train the patient to voluntarily hold the breath. So the chest wall is not moving during the treatment, and the treatment is more precise. SGRT means that it's called surface guided radiation therapy. We have a specific equipment. It's stereoscopic cameras that are looking to the patient surface, to the chest wall surface, and we have a reference shape of the surface, and the current situation, current settings has to be as precise as the reference one. So otherwise the treatment is not possible to be done. And sometimes we are also doing, we call it PET-CT verification. I catch the part of the previous presentation about the discussion about imaging of the patients. PET-CT is another imaging modality which is using radionuclides to display the activity inside the cells and to evaluate if it's a viable lesion or not. With protons, as I said, protons have a particle, so it is able to, the proton is able to produce also the radioactive material directly inside the patient body. And then we can display this such places with PET-CT scanner, and then we can easily see if we are really treating the volume we would like to treat. So this is another quality assurance measure to be sure that we are really delivering the dose to the place we want to have it. How the process is done. First of all, we have some team which is deciding whether the patient is eligible for treatment, because some of the patients are not. For example, if they have kind of pacemaker or cardio defibrillator. This is a sensitive electronic device, and it is usually placed close to the heart, which means in the chest area. So there is some scatter radiation, and this scatter radiation can damage the electronics of the pacemaker. So that's why it's not a good option to treat patients with ionization radiation if they have such a device implanted. Then the second step, if patient is found eligible for treatment, we are doing the training of deep inspiration Bezel before even we start any imaging or any other procedures. It really depends if the patient is able to hold the breath for significantly long time. We usually want to have to be able to hold the breath for at least 20 seconds. But some of the patients are not able to do so. So we can optionally do 4D CT scanning. So we do the CT scans in all the breathing phases, but it includes also that we have to make the target volume bigger to be sure that we have it all the time in the beam. So very preferred is the situation when the patient can hold the breath. Then the CT scan is performed in treatment position. Treatment position is that the patient is laying on in a supine position with hands above the head. So there is nothing in the way of the beam for the treatment. Then the treatment planning is done. The pictures I have shown are from the treatment planning system. So we somehow calculate how the breast wall must be irradiated. So we set up the beams, we set the intensity of particle pencil beams, evaluate the dose distribution, and if we fulfill all the constraints we have, so we are sparing the organs at risk enough, and if the target volume is covered well, then we do the last pre-treatment step before actual treatment commences. We do the pre-treatment simulation. So we put the patient again on the CT scanner to check the position, the shape, and the situation in the treatment area to be 100% sure that we will be treating exactly what we want. And then the prescribed number of treatment sessions is done. as I shown in this slide, 2 slides before, it depends if it's 25 plus 8 or 16 plus 4 treatment sessions. So the patient is coming to our center to do the imaging, to do the training, then the treatment planning and pre-treatment simulation and pre-treatment QA takes some time. So so at least 1 week is between first scanning on the CT scanner and actual start of the treatment. And then patient attends our center every day, every working day. We don't treat on weekends. So if the patient has 33 fraction, it means he is coming to our center for 7 weeks, basically every day. Just a couple of words about treatment outcomes. In general, as I said, we treated several hundreds of the patients. Maybe it will be more than 1,000 this year. So the patient usually tolerate the treatment without major problems. Sometimes, as I already mentioned, the compliance with deep inspiration Bezel may be a problem. Sometimes it happens that patient looks fine during the preparation phase, during the training. He can hold the breath for enough long time, but during the treatment his status may change or something may change, and he is not able to hold the breath in the phase as he was able during the training. So we have to do retraining outside of the treatment room, and for sure in this case we have to do the replanning. We have to also create new treatment plan and do the new pre-treatment verification again. Usually what is visible on the patient when you treat the patient with radiotherapy is some skin effect. It looks like a sunburn, and we call it acute skin toxicity, and this is usually mild. But for sure, if the tumor is infiltrating the skin, so the tumor is growing into the skin, we cannot spare the skin as a critical organ. And in this case, it's a target volume. So in those cases, there might be clearly visible the acute toxicity or the acute effect of the treatment on the skin of the breast. And there is one slide which tries to somehow reflect the current situation, and with epidemic or pandemic situation with COVID. For sure, we were also hit by this quite hard. For sure, in general, the treatment is adequately effective if the schedule is maintained. So, as I said, if the patient is coming, has 33 fractions, it should be delivered 5 fractions per week, not less, not more. Then we can estimate what will be all overall treatment outcome. If there are some interruptions in the treatment course, then the tumor control probability is somehow compromised. So our main aim is not to interrupt the treatment. With COVID, it was quite difficult because if the patient was simply become positive or he was at risk of being positive, then we have to make a specific measures. We treated patients even if they were positive, but we have to, well, if he was positive and he felt good enough to continue and undergo next treatment session. So if they have a mild COVID, then they were entering the treatment rooms as the last patients at the very end of the treatment day to eliminate the contact with other patients. This was one of the key measures we have to do. Basically, we did not interrupt the treatment because the interruption creates probably higher risk than the risk of COVID for other staff or people when you manage the situation well. So if the patient becomes positive or he was at the risk of being positive, then we put him to the end of the treatment day, so to not to be in contact with other patient. The room has to be disinfected for sure. We dedicated the staff group to take care of those patients. So these staff members make a specific shift that do not work any other part of the day, and they were not in contact with other staff members, because for sure, if a lot of people who are taking care about our patients will be positive or ill, then we cannot provide the treatment anyway. So for sure, if some staff member has symptoms, that they are not allowed to continue in work, not to spread the disease further. For sure, we have to wear protective mask all the time. And also, in a case of positive patient, they have a specific dress, protective dress. And regular disinfection of surfaces and workplaces also performed.
Vladimir, sorry to interrupt. We're getting a little bit short of time. Have you got?
I guess this is the last slide.
Fabulous, thank you.
As I said, this is the last slide. Last access information. So thank you for attention.
Thank you so much, Vladimir. Well, your talk certainly stimulated a lot of questions, so I think a lot of people are very interested in this. I'm going to introduce the next speaker, and then we'll take questions for Vladimir at 1 o'clock after the two speakers. Is it all right for you to stay for that, Vladimir?
Yes. Well, basically, I have to leave in 20 minutes. So.
Oh, that'd be fine. We've only got a 10-minute question slot, so that'd be perfect.
Okay.
I'll make sure your questions go first. Thank you.
Okay, thank you.
Okay, now I'd like to introduce a consultant breast surgeon from Ghana to give us really another completely different view on treating breast cancer in a different part of the world with different challenges. Dr. Mrs. Beatrice Wiafe is president and founder of Breast Care International, and she's also consultant breast surgeon at Peace and Love Hospital. So we'll hear her talk, and then we'll hear questions and answers from both speakers for this session after this at about 1 o'clock. Thank you.
Thank you so much, and thank you to all the organizers for inviting me to speak here. And so we are going to see a different perspective from what we've heard so far, because we are seeing palpable lesions and we are seeing very advanced stage breast cancer. So I'll be giving the view from Africa, even though I'll be presenting from Ghana. So what has happened and what needs to happen? The control of cancer is best brought about through a combination of cancer prevention and treatment. It requires significant infrastructure, manpower, and normally it's very expensive. And even the resource-rich nations have difficulty providing adequate, high-quality treatment to all of their population in need. And so for those of us in the low and middle income countries, we think our best bet our best option is prevention, especially preventing the late stage disease that we always see. We've heard about the incidents worldwide, and what I want us to note is the fact that according to WHO, over 70% of cancer deaths occur in the low and middle income countries, and we form majority of these countries. Most of our women are diagnosed relatively at younger ages. If we have about 58% of our patients below the age of 50, it makes breast cancer not only a matter of public health concern, but a developmental issue, an economic issue. In 2020, according to GlobalCan, about 4,050 new cases of breast cancer was diagnosed. You would think it's not a big figure, it's not a big number. These figures have our loved ones behind them. And you should look at the fact that about 2,020 of these died. So our mortality rate is high. Please forgive me for showing the following slide, which is of very advanced stage disease. And these are the cases we see on regular basis. In fact, about 60 to 70% of our patients come in these late stages, whether it's the man or the woman. But of course, women are more than the men. So Dr. Martin Luther King said that our lives begin to end the day we become silent about things that matter. And that is why in 2002, we founded Breast Care International to create awareness about breast cancer among the population, improve the diagnosis and treatment, advocate for acceptable screening and treatment modalities. We don't have screening mammography. We don't have it. So all we have is to train our nurses, our healthcare professionals, how to do clinical breast screening. And that's why I said we are diagnosing mostly palpable lesions. So the Breast Care International aims at also increasing the survival rates, reduce morbidity and mortality, establish a database for breast cancer through research. And there has been a lot of research ongoing. I must say here that I thank the Royal Marsden Foundation for similar research that we did. Training of manpower in oncology. To also fundraise to support needy or the vulnerable breast cancer patients and survivors. Why do we have so many late presentations? There are myths and misconceptions surrounding breast cancer. People think it's not curable, of course, because majority of them go late to the hospital. So the notion is that it's not curable. They think it's caused by witchcraft. They think it's a spiritual disease, and that is, it's by fate that a woman would develop breast cancer. They think it's as a result of a curse on a family, especially when you have positive family history cases. They think it's as a result of the woman's failure, and that women die from mastectomy. Because of these negative things, breast cancer is still stigmatized in our part of the world. But the woman has to overcome a lot of barriers, lack of awareness, inadequate or bad treatment. The cost involved in treatment is huge, above what the average woman can afford. The distance, all the treatment centers are in the cities. So the woman has to travel for hours, between 6 to 8 hours, sometimes more than 10 hours, before she can get to a center where a simple diagnostic mammogram can be done. Lack of counseling. We don't have counseling units in all the treatment centers. Lack of support, to the extent that sometimes husbands even run away from their wives when they are diagnosed with breast cancer. It's all part of the lack of awareness. So we start telling our people that breast cancer is no respecter of persons or profession. You have lawyers, you have doctors, police women, farmers, traders, the fact that teachers, everyone, every woman is at risk. We also take advantage of the media, the vibrant media. So the media helps us a lot in educating the people and creating awareness. We teach our women how to do their own breast self-examination. In certain settings, breast self-examination is not relevant, especially when you'll be having non-palpable lesions. But in our setting, it's very important. So we teach our women. We also use this model where the Breast Care International will be looking at the community, the screen and refer, creating awareness, and then the Peace and Love Hospital, which is a sister hospital. That's the diagnosis and treatment, palliative care, survivorship, reintegration, and all that. We go out to the communities, to the churches, to the workplaces, to the schools. We believe that if we educate the students, they will grow with the knowledge and they will help us to educate their mothers, their grandmothers. After the education, we do clinical breast examination where we look out for these kind of lesions, lumps, abnormal discharges, changes in the breast that the woman may not identify herself. And sometimes people think that it's only when there's pain that they have to go to the hospital. Once there's no pain, they think there's no danger. So we do these screenings in the community to help them, to help identify early stage disease. We've been doing these nationwide yearly walks for the cure. We started it as a Susan G. Komen Ghana Race for the Cure. And after the second year, we turned it into the BCI Ghana Walk for the Cure, where we gather women, men, students, children who can walk to come and join us and to walk for the cure. We've been having our presidents, past presidents, our first ladies, and in 2017, we have our first lady walking with us for the cure. In 2019, we had the last walk because COVID-19 came to interrupt us. So in 2019, we had 43,000 people walking for the cure. Our walks are not for fundraising. They are mainly for awareness creation. We realized that the educational levels are low. So we started training our people in basic oncology, training for the nurses in the communities, training the media. Our media is so vibrant when it comes to football and politics. So we decided to train them in basic knowledge about breast cancer and cervical cancer. And sometimes we add prostate cancer as well. The breast health promoters who happen to be the spouses of Presbyterian ministers. And we plan extending this to other churches. We also trained our survivors as peer navigators. So they will share their stories, their personal experiences with the newly diagnosed women. And this program, we call it the HOPE program, has been adopted by the Advanced Breast Cancer Alliance as a toolkit. We've also been trained the young ambassadors. So the breast cancer survivors were brought together, and it was all to improve the quality of life of the survivors. and also to bring together those who have survived it and to serve as, a mirror for the newly diagnosed ones. It gives hope. It helps to demystify breast cancer and remove the fear surrounding it so that other women will know that we have people who have survived the disease. So we have fun during these walks using our breast care international's ambassadors who are musicians and people who we call them influencers. We normally also work with the survivor babies. These are children whose mothers are survivors or who have lost their mothers to breast cancer. Sometimes some of them drop out of school, and so we need to look for them and help them to integrate and go back to school. We do, sometimes we gather them, get materials from the Ghana Textile Print, GTP, and then we, sew it for the survivors to have fun, so we do photo shoot for our breast cancer survivors. Through these programs, we were invited by President Bush and the wife, Barbara, to join the panel to discuss the pink ribbon, red ribbon at the Bush Institute. We're also invited by President Joe Biden and the wife to dinner in the White House, which we see as a pat on the shoulder. Our partners, Direct Relief, has been sending us donations of, medications and equipment, which we in turn donate to other hospitals and clinics. And they has been going on for years now. We are grateful. I want to show the picture of a survivor who gave her consent when she came to us. This was the first day in the hospital with this huge tumor. And she had been going from one prayer camp to the other, one herbalist to the other, until she got to us. We decided to give her the chance and did mastectomy, chemotherapy, radiotherapy. And after that, she has relocated from the central region of Ghana to Ashanti region to join Breast Care International and the Peace and Love Hospitals. She's now a member of our staff, and she has volunteered her life to show her scar and her prosthesis during our outreach programs. So we say breast cancer has been exposed. There are a lot of activities. We say, what's the way forward? We should continue with the education and awareness campaigns and the screenings. The training for the nurses and peer navigators should be ongoing. Education should be a dynamic process. We also have a program, the Bus Stop Cancer Project, where we think that we should educate our people at the bus stops, the bus terminals. I'm going to show a few slides on that. Support for the poor breast cancer patients and survivors. If we need to have survivors, more survivors, who will help us create more awareness, demystify the disease, and also to encourage more women to report early to the hospital, then we have to support them to go through their treatment. We also have been providing audiovisual documentary, which sometimes are played on the buses. So the Bus Stop Cancer Project, I want to touch briefly on this. This is a typical bus terminal in Ghana. And you see how it's crowded with the buses and so many activities. Another bus stop. And so you realize that these patients do not have time to even go to the hospital for screening or to go somewhere to get themselves checked. And most of these women, these people who patronize the buses are women, because they travel to, go and buy things from point A to point B to sell and to make money to support their families. A lot of these women are single mothers, so they just have to work. And so we are thinking of getting the right equipment for that program. So this was a program we did. And if you see behind me, that is an improvised closed tent that we were using for the breast screening because we don't have a closed tent for use. This is the type of tent we are talking about, which we need to purchase for the activities for the breast, the Bar Stop Cancer Project with an air conditioner because it's always very warm. The temperature is normally around 30 degrees. So you cannot use a closed tent for screening without an air conditioner. We need the PA system to use for the education so that if the woman is even engaged in something else at the bus stop, she can hear what we are saying. She can listen to the education that will be given and the awareness creation. And we want to get this kind of setting where this was seen from the Church of Pentecost, their national convention, where they provided a closed tent and an open tent for the education. So this is the setting that Breast Care International wishes to procure. And so members on this platform, if you think you can help us to get this setting for the awareness creation, please don't hesitate to contact us. I think the organizers in Geraldi will be there to help us to get the right people to support us to do this kind of job that is necessary. So there are a lot of research gaps also in survivorship in the low and middle income countries, and we are ready to do collaborative research in survivorship. And for the subtypes of breast cancer, we have majority of our women are with the triple negative disease. And we are aware that is one of the difficult subtypes of breast cancer to treat. And so, but we know that if we find them early, we can manage them well. There's no social support system in a part of the world. So for the vulnerable women, it's important that we do some fundraising for them. If you visit www.bciamerica.org and you hit the donate button, you can donate to BCI America, which will be used for the activities in Ghana for Breast Care International. And in my conclusion, I want to say that it behoves on us as those who can make a difference to do everything in our power to save as many lives as we can. Let's all join in the fight. We are stronger together. And please visit our website and just share your views, ask your questions if you are not able to ask them now, and let us do what we can to help our people. Thank you so much. Thank you for inviting me to share these slides with you.
Thank you very, very much, Beatrice. I think everybody is sitting here quite stunned from your presentation. I mean, those pictures of Late's presentation were really quite shocking, and the steps that you've taken to address it are really just quite incredible, and I think we're all in awe of you, quite honestly. If you can hang on for the question and answer session as well, I've got some questions coming in. I know Vladimir needs to leave quite soon, so I'm going to deal with Vladimir's questions first and then go on to your questions, if that's okay. So Vladimir, you're still here, are you? Vladimir, are you on mute?
Yeah, he's on mute, but I can see him.
Okay.
Okay.
Okay, so I do it all the time. So Vladimir, questions for you. One question is the efficacy of photon therapy for multilobular breast cancer, where obviously there's not just necessarily one solid lump, but there might be lots of diffuse lumps. Is it suitable for that?
Well, basically all the patient cases which are eligible for photon radiotherapy can be in principle treated with protons. This is I guess a general answer, but we really evaluate each patient case about the eligibility of the particular treatment approach. Sometimes we can see big difference, so these patients can clearly select where to get treatment. Sometimes, but usually the proton treatment is more or is better from the point of view of the dose load to the healthy tissues. If you treat with photons, you are treating a lot of healthy tissues as well, and with protons, the treatment is more conformal. So this is how we usually evaluate it.
Okay, thank you. Now, I know that at your centre you treat a lot of people internationally, both within the EU and outside the EU. And there's a question on this, your view on international treatment and ease of movement.
Yes, we do the treatments. We have in the EU here we have some kind of international possibility of insurance of the patient. So for a lot of European countries, there is a possibility for patients to come here, and there is some paperwork, and usually their insurance company will pay for the treatment. We can treat patients. We treat a lot of patients from UK as well. We treated a lot of patients from Slovakia, for example, which is the country with the highest number. I mean, the Slovak people are the most frequent minority in our cases, because major of our patients are Czech patients.
Thank you. And then one final question, slightly sensitive one, but one of the delegates actually asked about protein therapy at a local hospital, which is a large cancer centre in the UK. And she was told that the research hasn't been complete yet for breast cancer, and so she was not offered this treatment. And she'd be interested in your comments.
Well, as I said, it's hard to make any comments on a particular case, because as I said, we evaluated on individual basis. So in principle, maybe for some reason they do not offer them a proton treatment. This is really hard to say. I cannot say why colleagues in different hospitals makes such a decision.
Okay, thank you very, very much, Vladimir. I mean, I'm sure we've got more questions, but it's been an excellent talk. I know you've got to go now, so thank you very much for sharing that with us. Really appreciated.
Thank you very much for inviting me, and take care.
Thank you. Now going over to Beatrice and situation in Ghana. I mean, I think, first of all, I'd just like to say that I think the work you're doing, Beatrice, is amazing. And you did share the details about your charity, which, I mean, I don't think anybody would argue is a very important charity. And perhaps if we can have those in an easy shareable format somewhere, Anna, and if delegates would be willing to share this on social media, I'm sure this would help Beatrice a great deal to try and get some funding in. Now we've got a couple of questions. The first question is about taking on board the cultural values and belief, which you explained so very well in your talk. I mean, obviously it's hard anyway in a country where distances are a big issue to to educate, and I know you're doing a great job with education, but some of the beliefs, I know you've talked about this a bit already, but maybe you can expand on what's almost the quickest, easiest way to address these barriers to people seeking treatment.
Yes, thank you so much for this. It's actually very important to try to change the cultural beliefs of people and the way people do things. And you understand that it's not easy. It can take a generation before some beliefs can be wiped off. And let me give one small example. We went to a school, a senior high school recently, and one lady was asking a question that when the breasts are coming, normally they apply some insects to your breast so that it can help it to develop bigger. So will that have effects on them? And I was shocked because when I was also a teenager, in fact, when I started developing breast, that was the things we were doing. They were giving us insects to apply to the breast. And this is a generation that can be at the age of my granddaughter, and they are still doing it. So it means that it's being passed from one, generation to the other. And it will only take education and awareness creation to make things happen the way we want it, to change the narrative. And that is why I believe that we should concentrate on the children, the schools. And if we are able to start the education even at the junior high school level, so that they wouldn't believe that breast cancer is caused by witchcraft by the time they grow up, because they can now go to the internet, they can Google for information, which was not there previously. And also in the older generation, a lot of women cannot read nor write. The educational level is too low. And so people just get information from what hearsay. And so we believe that with time, things can change, but we need to act as catalysts to cause the change that we need.
Thank you, Beatrice. And then there's one final, it's kind of a question and kind of a comment, but I think it's quite important. And it's from somebody in East London, initials SS on the chat. And what she's saying is that in her area of London, it sounds from what she's saying, I'm interpreting, as if there's a large African community there she's dealing with. And she's saying that those kind of late presentations that you showed, they're also seeing actually in East London. And she's been working with a radio station called Voice of Africa. So I think part of the question is relating to fundraising and your approach. And I also think if you're willing, might be very good for you and this lady, and sorry, I only know the initials SS, but SS, if you can maybe make contact with Beatrice and you can get together, because you might well have a lot that you can share information on that.
Yes, I will be happy to collaborate, have interactions, because we've been also doing a lot of radio interviews. And you see, if I read the comments, these are old people with comorbidities. So if they have advanced stage breast cancer, it's probably because they couldn't diagnose them at the right time. They couldn't give the right treatment because of their condition. But we are talking about young women. We are talking about women in their late 20s, in their 30s, and in their 40s. Our mean age is 43. And so breast cancer strikes earlier. And like I said, our subtypes are more aggressive, grade 3 tumors and triple negative disease. And so we should be more aggressive in our awareness creation exercises. and make sure that our people report early. And I also mentioned that when there's no pain, our people think there's no danger. And we know breast cancer doesn't start with pains. And so we have a difficult task on hands. And that is why we are asking everyone to come on board and join us to change the narrative in our women, because women are dying needlessly, prematurely, leaving their young children because they didn't come to the hospital early.
Thank you, Beatrice. I think you make a very important point about the fact that it's often young women as well, particularly in your demographic. But also, I think it's important to remember that young women, although it's rarer, can get breast cancer in any country. And a woman should never be ignored, whatever her age, if she is concerned about her breasts. And also your important point in the talk about men can also get breast cancer. And I think we can't forget that either. I'm going to have to finish this now because it is the lunch break, but thank you again. And I think there's been a lot of chat messages to you about contacts for supporting the charity. So I wish you every good luck in the world with this. So we've now got a break until 1:40, and we do need to come back promptly, I'm afraid. During the break, the Zoom will be open, and you can either chat to people publicly, or there's a private facility just to chat to people that you want to chat to as well.